Two vascular surgeons walk into a bar and come out with a podcast. We are talking everything vascular and not. Welcome to the Life of Flaw podcast.
The following podcast is not relating to my teachings and work at Del Cedar Medical Center and is for entertainment purposes only. Hello, everyone. Welcome to the Life of Flaw podcast. And today is a great episode. Today is, for me, something special because we have one of the people I look up to a lot in this field, Dr. Roberto Ferraresi. He is the head of Peripheral Intervention Unit and Scientific Director of the Diabetic Foot Center at the San Carlo Clinic in Paderno.
Your Italian is fantastic.
In Milan. Anyways, we had an amazing conversation. Every single time we talk with Roberto, I think we should just absolutely not talk and just let him
go.
Let him go because he's just a depth of knowledge and passionate and
Good
way better speaker than we are. So hope you guys enjoy.
I'd say the contemporary godfather of DVA. So stick around. Lots of fun facts from his past.
Let's go. All right, everyone. Welcome to another episode of the Life of Flaw podcast. Roberto, this idea for this podcast started 2 years ago at Link at a dinner we had at an Italian restaurant, which was very good. After that, I was like, man, I want to have more of that. And then I went to Miguel.
You mean the food?
No, of conversations. Yes, and the food. Actually,
So we should do a cooking show instead of a podcast.
Yeah, exactly. That's my next one. But this all started because that day I just had the best dinner ever. Because I was listening to the stories, everyone's story.
It was Italian dinner.
Yeah.
Italian food with Italian.
Yeah, exactly.
Friends.
And that's when, and then I just, one day I was with some friends and you know what, this is what I want to do. I want to replicate what happened at that dinner. So I called Miguel, Miguel, we're starting a podcast. I don't care what you want to say. We're doing it. And 1 year later, we're here and we're recording with you, which you were at the dinner.
That's very interesting.
Yeah.
I didn't know.
Yeah.
So Italian food inspired this podcast.
Yeah.
Okay.
Exactly.
Italian food in Leipzig.
Yeah, exactly.
That's good.
Yeah.
So Roberto, for the audience, we're here in Leipzig in Germany. This is part of our recordings under the Link Leipzig Interventional Course Meeting. And I appreciate you spending some time with us. And I think probably everybody that is involved in this knows you by name, knows your last name, knows your work, has read some of your articles, has seen some of your presentations. But I'm sure that not everybody knows, the path behind the legend. And I would love us to spend a little bit of time on understanding how you got to this position and how you got to fall in love. I don't know if you love or not, but it seems like you do love what you do. And how did you get into the vascular world? What was the path?
I started to be a cardiologist about 40 years ago. At the beginning, I started with implantation of pacemaker, etc. Then I built up the hemodynamic part in my cardiological department. And it was in Magenta, a city which was about 30 kilometers on the west of Milan. And at those times, coronary angioplasty started about 48 years ago, and 48 years ago. And at those times, I was only an operator who started to do what was invented and done better than me in other centers, in other big centers. So I was only one of the original interventional cardiologists that tried to do what was taught us by Grunzig, Colombo in Italy, etc. And in 1999, in an hospital very close to mine, there was a foot surgeon, an intervention foot surgeon, was Caravaggi, one of the pioneer of diabetic foot treatment, asked me to do the same that I did at those time on coronary in peripheral. And I said, but there is nobody going below the knee. It was really something that very few people were done at those time. And I remember that I went to see Lanfranco Graziani, one of the first pioneer, and I have appreciated a lot this type of treatment. And so I started in 1999 to treat this diabetic foot. And for the first time, I realized that I was a pioneer. There was nobody to treat the diabetic foot. So in coronary artery, it was only an operator trying to do what other physicians have invented and done better than me. But in this field, I was John Wayne, Far West. So no rules, I am the rule.
I love that.
So,
yeah.
and it was unbelievable because we started with the coronary material. So the main length of a balloon was 2 centimeters. And to treat 20 centimeters of anterior tibial artery or posterior tibial artery, you had to inflate, deflate, pull, inflate, deflate, pull, inflate, deflate. And so we started to talk with companies. I remember an Italian company, very famous, Invatec, who invented the first inferior deep balloons for BTK that is still on the market and is still one of the best balloons, in my opinion, for BTK.
Yeah, that company was purchased by Medtronic. So they're a Medtronic balloon nowadays, inferior and
deep. It
deep.
is a Medtronic balloon, yes. And so year after year, the material improved a lot. At the beginning, it was a nightmare because antegrade femoral puncture was something very difficult. And in my first 100 cases, I remember that I got at least 8 major complications. So I was very worried. But you have to remember that at those times, every stent, peripheral stent for superficial femoral artery, was at least 7 French compatible. And to do an antegrade femoral approach without knowing the correct way to do it, because it was an experimental approach with the 7 French, it was a nightmare. Retroperitoneal hematoma, scrotal hematoma, huge abdominal hematoma. So it was a problem. But I remember now that in 2004, when I was able to do my first 4 French antegrade femoral puncture and treatment, and the first 4 French compatible stent was the Expert, which is still on the market by Abbott, but at those times was by Yomed. And it was for me safety, no more complication. And to understand where to puncture the common femoral artery or the proximal superficial femoral artery, looking at the X-ray mark of the femoral head. And when I was able to avoid every major complication of retroperitoneal bleeding, etc., for me it was like to go in pellegrination to the Madonna of Medjugorje, something that, no more complication. I can do 4 or 5 procedures every day, no more complication. It was really a change, a game changer.
Was there a point in your career that you had to forego coronaries and say, I have to 100% just do legs every day? And was that an easy decision?
It was about 20 years ago. It was a very difficult decision. But I had so many patients with critical ischemia coming to my cath lab that I was no more able to continue my coronary and cardiological activity. So I shifted completely in peripheral.
Why do you think still there hasn't been an adoption of antegrade approach for BTK? I would say at least in the US, maybe 20% of people do antegrade. Why hasn't it been integrated more? Why are people going up and over to go down to the tibials?
I remember that about 20 years ago, I had many discussion with Professor Biamino, Giancarlo, because Giancarlo was for a contralateral approach. But I said him that antegrade femoral approach was the only approach able to give you the total control of BTK treatment. That by contralateral approach, in my opinion, will never be complete, absolutely independent from the material. Antegrade femoral approach means to be able to go there directly without any problem. And at the beginning, Giancarlo was contrary to this approach. He said that it was very dangerous. I said, yes, it is dangerous, but if you do it properly, you have the same complication of a retrograde approach, standard contralateral approach, etc. Today, I believe that a antegrade femoral approach must be the correct approach in more than 90% of patients with chronically threatening ischemia, especially because chronically threatening ischemia is a disease of the small vessels, of the distality. It's not a disease of the big artery in the vast majority of the cases.
I primarily, I think it's just a lack of training, because the moment that you get comfortable at it, you never go back. So I've never heard of anybody that said, I did a ton of antegrade approaches and I stopped doing it and now I go up and over, because that's just simply a lie. The pushability, the control of the wire, your capacity to, it's just, I would, however, say it's very important to have a good ultrasound, or some sort of imaging ahead of time, so that you know you're not missing important stuff in the iliacs or inflow, or there's a common femoral issue that you need to do. But if you got all those ducks in a line and you start doing it and you feel comfortable, and now, I mean, I'll do people on full Coumadin and everything antegrade, and I'll just put a closure device and it works phenomenally well, and the patient go home in 2 hours from my lab, and it's not a problem. It's not a big deal. But at the time when you started this, Roberto, and you decided, okay, I'm going to just focus on this. I have so much CLI. I'm not going to do coronaries. What at the time seemed like the biggest challenge? What was at the time what still needed you to be John Wayne and trailblaze, at that time? Because we're talking about 20 years ago, right?
Yeah. The first thing is that I stopped completely my career, because I was no more a cardiologist, so I cannot be a chief of a cardiological department. I never was a vascular surgeon, so I cannot be the chief of a vascular surgeon. I never was an interventional radiologist. So from 20 years, in the last 20 years, I was the chief only of myself. And so I had to move from the Statal hospital to a private hospital. In Italy, the private hospital have a convention with the regional governments, so patients are paying nothing, are always under the health system, Italian health system. But you have a private contract, and you can write in this contract what you want. The chief of the peripheral hemodynamics department, and now I wrote scientific director of the Diabetic Foot Clinic, but I had nobody under me. This is the first key point, absolutely. The second problem is that to be a pioneer means that you go out of the natural scheme. So the main problem is that in Italy, which was one of the countries where diabetic foot and critical limb ischemia were firstly treated properly, they were treated properly by diabetologists. The main foot surgeons in Italy are diabetologists. Caravaggi, De Giglio,
What is a
Uccioli.
diabetologist?
Diabetologist
We don't have
is
diabetologists.
Like an internal medicine,
Internal medicine.
an internal medicine.
Internal medicine,
subspecialty like endocrinology, diabetology,
Exactly.
and then
They
they would
operate.
do surgical training. Correct.
Yeah.
This pioneer moved from an internal specialty to surgery because orthopedics
Wouldn't
never
do it.
wanted to do
They wouldn't do
diabetic
it.
foot. They have prostheses. They earn a lot of money with prostheses. They have trauma. They have these big things. They don't like rotten feet.
Yeah.
Absolutely, especially in their department. A rotten feet, something that. Vascular surgery. They move to aorta, to carotid, sometimes bypasses, thromboendarterectomy, but they don't like foot surgery. So cardiologists do this type of treatment, but generally they have not the knowledge necessary for all the other treatment, surgical and internal treatment for diabetic feet. So this is a big problem. And the second key point for me was to be able to enter inside surgeons' mentality and to teach that vascular surgeon must today face and treat critical limb ischemia. Because in treating critical limb ischemia, diabetic foot, ischemic diabetic foot, call it as you like, you need essentially to be 4 skills. The first one is the endo skills of revascularization. The second one is the open skills of revascularization, because endo cannot do
Everything.
all the necessary for revascularize. So you need also physicians able to do distal bypasses, thromboendarterectomy, etc. The third skill is foot surgery. And if you are a vascular surgeon, you can do foot surgery. You can learn foot surgery. The fourth skill is all the internal part. You need a diabetologist. You need cardiologist. You need the infectivologist, all this stuff. So you need the internist able to say you what is exactly the domain where you can move in doing interventional treatment to the patient. But vascular surgeons can cover all of these 3 parts, interventional parts, that are typically of vascular surgery, in my opinion. And now in Italy, something moved, because now I am respected in Italy by vascular surgeons. And also abroad, because, for example, it's 18 years, I think, that I invited in the VITHA Symposium, which is a typical symposium of vascular surgeons. So this is something that I was able to do, to move my knowledge from cardiology to vascular surgery. This was very important. For example, 1 vessel disease, 2 vessel disease, 3 vessel disease. This is the typical terms of cardiological approach that I applied on below the knee vessel.
Roberto, I want to say you and I were at the same podium not too long ago at VEITH, and we were in a session of the no option CLTI patient. And Dr. Veith got up to the microphone and asked a question. He said, I don't understand how you guys are quoting 15% or 20% no option CLTI. When I was in practice in Montefiore, many years ago, I would say that maybe less than 1% or less than 2% of patients were patients I couldn't do anything to. And, I at least, this was the answer I gave him. And I said, I just think that the patients have changed. I can see it through my own career where, I've been doing this for 20 years now, and I see very different patterns of disease. Before, it seemed like, let's go before. When I was here in Leipzig, I saw a lot of Leriche, a lot of aortoiliac disease from World War II survivors that were on 2, 3, 4 packs a day of cigarettes. A lot of common femoral disease and femoral popliteal disease. Then when I was doing my career initially, I saw a lot of fempop and like tibial disease obstruction, but with good outflow, where you could do an angioplasty of the tibial artery and a bypass facility. But in the more contemporary part of my career, I stumbled on what you have been essentially noting way before me, certainly, which is this overly distal below the ankle and what you've termed rightfully so small vessel disease, the SAD disease. And so I stand by that answer where I think, probably back in the days, he had less small arterial disease than what at least we see nowadays. But I'd love to know from your standpoint, because this was obviously, it's almost like you taught me that this existed. So it was easy for me to recognize the pattern once you foundationally laid what that pattern means. But how was that for you? How did you started noticing and at what point did that light start going off and saying, this is something that I haven't seen before, and I start seeing more of it? Can you recall a little bit of the history of that moment of eureka and identification that there was something different that you hadn't seen before?
At the beginning, I totally agree with you. At the beginning, we faced essentially a pure atherosclerotic disease, which was typical of the last 80 years after the Second World War. We had a good food for everybody. And so we know everything about atherosclerosis. Atherosclerosis is a lipid plaque-based disease, focal and multifocal. And if you look, for example, there is a paper that I like to mention, a paper by Debeke. Debeke, one of the father of vascular surgery or cardiac surgery. In his hospital, he collected more than 18,000 patients from 1948 to 1983. And in 1985, he published a paper, big paper, Journal of Vascular Surgery, beautiful paper, Patterns of Atherosclerotic Disease and Their Surgical Treatment. 18,000 patients. And he said type 1 atherosclerotic disease is coronary artery, type 2 carotid artery, type 3, quite rare, visceral artery. Type 4 is peripheral artery disease. And he put some images of this peripheral artery disease without the fit. No fit. Mean age of his patients, 57. Diabetes, this word diabetes is only one times in the late discussion presented. There are some patients with diabetes that have a different pattern. At those times, between 1948 to 1985, the prevalence of diabetes in USA was less than 2%.
Wow.
Less than 2%. Today, with the diagnosis of diabetes, I think we are about 10 to 12% of the patients, and probably 20% of people in USA have diabetes. This is the rule. So at those times, atherosclerosis was the main cause of peripheral artery disease. But now, in my cath lab, the mean age of the patient is about 74, 75. 86% of my patients have diabetes. 20, 25% of my patients are on hemodialysis. So risk factors change completely. And year after year, I understood that small artery disease was the main cause of critical limb ischemia, a rising cause of critical limb ischemia, and it was not atherosclerosis. Tomorrow, we will present a study that we made with the University of Parma on 26 amputated limbs due to unreconstructible foot or unreconstructible vascular disease. Okay, 26 consecutive patients. We made sampling of superior femoral artery, proximal, medial, distal, popliteal artery, proximal tibial, distal tibial, and foot artery. Now, atherosclerosis was present in more than 80% of the superior femoral artery samples, in about 70% of the popliteal artery samples, in about 30% of the proximal tibial artery samples, then disappeared. No one lipid found in the samples of the distal BTK and in the foot arteries. Medial artery calcification was everywhere. But medial artery calcification, by definition, is not obstructing the vessel because it's in the media. What we found strongly associated with medial artery calcification is intimal thickening. And intimal thickening was present everywhere, but intimal thickening became obstructing in proximal BTK, in distal BTK, and mainly in foot arteries. So what is today causing chronic lymphocytic ischemia is the mix of two diseases. The first one is the big artery disease due to focal and multifocal atherosclerosis. The second one is medial artery calcification and intimal thickening, which is present everywhere, but which becomes obstructing only in tibials and in foot arteries. And the proximal BTK arteries are the overlapping zone in these two diseases. This means, for example, if you look at all the studies regarding drug-eluting stents, balloon expandable stents, self-expandable stents in BTK, the mean length of these studies that are more than 30, I think, in the last 20 years, is less than 4 centimeters. And the vast majority of these stents were put in the proximal third of the BTK arteries. This means that all these authors have concentrated their effort on the atherosclerotic focal part of the disease in the proximal BTK artery. If you look at all the studies on uncoated balloon and drug-coated balloon in BTK, you can see that the mean length of all the studies that are more than 25 is about 16 or 17 centimeters. 5 times of difference with the studies on... and the length is so much that they extended their treatment in proximal BTK and distal BTK. So there are a lot of meta-analyses today and a lot of studies comparing device A versus device B that were done without considering the length of the lesion. So different population of patients, different type of lesions. How can you say that this device A is better than B when the lesion treated here is 3 centimeters and there is 20 centimeters? How is it possible? I remember that in the congresses, people were laughing at me because Siablis, I remember that in 2005, published a paper with the first magical cipher drug-eluting stents in BTK. 14 millimeters of lesion treated. 2 years later, I published the first paper with isolated BTK lesion treated with uncoated balloons, and my mean lesion length was 22 centimeters. Mm-hmm. And everywhere in the congresses, everybody says, drug-eluting stent, now, this is the duty for every physician working on BTK. This is industrial medicine. This is shit.
I love that.
This is shit. Correct. Why I have to treat 20 centimeters, more than 20 centimeters every day, 30 centimeters of vessels, and you 60 millimeters, and you say limbs with 16 millimeters? There is something wrong. Or I am wrong, or you are wrong. But both cannot be right.
So for many years, you were ballooning these patients, and I'm guessing this is what you were seeing. There is a famous book by one of my favorite authors. In Spanish, it says "Crónica de una muerte anunciada." And do you understand this? And I don't know how to translate it into
Chronicles
English.
of an Announced Death.
Something like that, I guess.
Like that,
yeah. And that's the way I felt when I would find these patterns of arteries that at the time I had no name for it. I was just dealing with it. And I would preface these conversations with, I'm going to see you every 3 to 6 months. And I'm going to have to touch it up every 3 to 6 months. And every time I go in, it's going to be harder. And there may be a point where I just can't do anything. So it was like this, it was horrible. Because think about this. You go to this doctor. He's supposed to be really good, well-trained all over the world. And you see him and he says, yeah, so you have a shit disease. I don't know what I can do, but I know I can balloon it a few times. And then one day I'm just going to not be able to do anything and I'll probably cut the leg off.
Because what we do is palliative surgery.
Well, what we do in everything in vascular is palliative, period.
Exactly.
Right?
Yeah.
I mean, and that's something you have to just understand.
Yeah.
But some is less palliative. Some just last a little bit longer. But this was one thing that I started noticing. And it was this almost like the streets started becoming less and less and less. And you got to a point where now you were in a corner and against the wall and there was not much you could do. Did you find this experience also something that you had noticed in your practice?
Yeah. I mean, probably that angioplasty was invented by cardiologists. And the idea of Peterson is an idea that was born with restenosis in the coronary arteries. So the problem is that with heart, you have a pathophysiology which is very simple. You need a body and you need some movement, some exercise. So if you have a patient with angina and you treat with a stent a coronary artery, you need patency because you know that after the treatment, the patient has no more angina. But after a few months, if you have restenosis, he surely will have angina again, at least angina by effort. Okay? But the pathophysiology of the foot is totally different, especially in diabetic. When you have a foot of a diabetic patient which is ischemic, this foot is generally asymptomatic due to neuropathy, etc., due to the high capacity of foot tissues to survive with long period of ischemia. During the night, the metabolism is replaced, etc., etc. In the vast majority of the cases, the foot becomes infected. And this is the reason why diabetic foot is an emergency, a surgical emergency, etc. Infection is a stress, is the stress test for foot tissue because every type of healing is blood flow dependent. So you need to open these arteries in every way, otherwise you will not be able to save the foot. Okay? When you have restenosis and the infection is treated and the foot is completely healed with minor amputations, etc., you will come back to the previous situation of asymptomaticity. And in the meantime, you need the proper shoes, the proper hygiene of the foot, you need surveillance, etc. So restenosis is not the same in heart and in foot, because life is a stress test for heart, but infection is a stress test for foot. And if you avoid infection, probably you can survive a lot. It's totally different in case of the diffuse disease, or what I call SADMAC, etc., where you have lesions that are purely ischemic lesions that are totally different from infection, because you have this lesion of the last meadows, the digits, the tiptoe, or the heel, and these are pure ischemic lesions. And in this case, if you do a revascularization, if you are able to do a revascularization, the survival of the foot will depend on patency, obviously, because in case of restenosis, you will have the same lesion again. So pathophysiology of the foot is totally different and more complex than pathophysiology of heart.
So in the setting of what we know today, and I know this question may be a little bit asked backwards, but in the setting of what we know today, and in the setting of having the deep venous arterialization as a tool, do you feel that today some of these patterns of uber distal, highly calcified medial artery calcification, when you see them, do you think there is still a role for conventional angioplasty at the beginning? Do you do it once or twice before you consider doing a DVA? Or are you at this point in your career quickly resorting to a DVA at an early stage to try to, and we'll talk about this a little bit more later, but to try to maybe change the natural history of the disease in these patients? What is your algorithm today? And then maybe we can jump back to when you started doing DVA. But I feel like this is an interesting question here.
I think that today we have some, for example, the max score.
Correct.
The max score is something that when it's 5, when it's very high, clearly gives you a prognostic evaluation of the patient, which is clear. At 2 years, only 20% of the patients are able to heal. This, I mean, is sufficient to consider this patient an option patient, where you can start with DVA. And another question is that sometimes despite our classification, despite the MAC score, despite the SAD score, etc., sometimes we are able to do revascularizations, probably directed to the wound, etc., that are able to get some healing. So I believe that every patient is different. This decision was tailored on the patient, on life expectancy, on quality of life expectancy, on the type of the lesion of the patient, and in attempt to do something despite the small artery disease is something that I do quite always to this patient. Then I check clinically in few weeks. 2 weeks are sufficient. I check clinically if I was able to get some clinical results. Otherwise, I move to venous arterialization.
Do you think there's any role for, say, there's a heel ulcer, you can get direct flow to the heel, but there is a very high MAC score. Do you think there's a role for an adjunctive DVA, if technically feasible, as a kind of
Like a backstop
to a future recurrence?
I think yes. But I think also that today our knowledge regarding the function of venous arterialization is still so poor that we need more time because we need to guarantee the result. Today, when you do a venous arterialization, in some cases, you precipitate an acute ischemia. You precipitate a worsening of the lesions. So today we have no quantitative data that are able in some way to guide foot vein arterialization towards a higher level of a good result of success. More or less, we are about 70% today of success of limb salvage, healing, etc. More or less, depending on the selection of patients, the type of arterialization, hybrid, total percutaneous, superficial, deep, etc. More or less. So this means that we have a 30% of patients in whom foot vein arterialization can deteriorate the situation and precipitate a major amputation. I hope that in the next few years we will be able to save more limbs. If we would be able to guarantee a 90% of healing a limb salvage, probably we could have a broader application, a broader indication for foot vein arterialization.
Yeah, I'll put it in my own words is I face the same where I almost know. I do a MAC score evaluation because at this point it's immediate. I just see the X-ray and I can do it in my head. It's relatively, for any one of the audience that you haven't, look at Roberto's paper. It's in the Journal of Endovascular Therapy, and it essentially details how to do a MAC score. It's a very, very quick tool, easy. You do it on an AP view and a lateral of the X-ray by just looking at tracks of calcium in the foot. But here's what happens to me is I see it and I already know this is a disaster. And I already can imagine what the foot's going to look like. And then I start evaluating all these things in my mind. And yeah, I can probably get a wire down there and I could probably put a little CSI or a balloon and get it to look better. But I know it's almost like it's going to come back. And I know it's probably not going to be the great thing. And so I start, I start thinking, should I go to it a little bit faster? And the only problem right now that keeps me from doing that is knowing that some of those patients that are in this limbo where I can get them a little bit better for a while, but they're not perfect. And I know there's going to be a lot of restenosis and ischemia again, and the wounds are going to come back. The problem is that the moment that we have to cross the bridge of DVA, it's either going to be success or major amputation. Because it either goes well, 70%, or there's a good 10 or 15% that I'm actually going to accelerate this and make it worse. Well, and there's no way to stop this.
Since we've talked about modulation of flow volumes, and I think we agree that a flow volume around 100 milliliters per minute is safe. Since you've implemented that, have you lost a
Yes.
limb? Yeah,
Yeah.
I have not.
Yeah. I still have had a very, very, very contemporary, I want to say like a month ago,
Yeah.
patient that I literally remember. Because the good thing about Hope is I have Jill Somerset, the movie rock star of ultrasound.
Yeah, I'm jealous. Yeah.
I have Brian Lipo, a phenomenal podiatrist, multidisciplinary group. And this lady, I asked Brian to do a TMA, has a class 2 pedal acceleration time, which should be enough. Very, very, older lady, dialysis. I'm not sure she's going to be alive for that long, but, anyway. And we do the case, and the TMA dies some. Not totally, but dies some. And initially they were like, okay, DVA. And I was like, no way. I think we're going to lose this battle. If I deviate, the substrate, there's just something about the disease and the state of frailty. Roberto maybe puts it in the term of, if I don't believe this patient is going to be alive in 2 years, maybe it doesn't make sense to do this DVA. For me, maybe it's also a degree of frailty. Because, do you even have enough prealbumin to get to where we have to get? This is going to be a slow road of 6 months and I kicked the ball and I pushed him back. I said, no, we're not. I'm going to touch it up. I'll go to the back to the angio. I'll do normal. And it kind of started to heal, but then she started to have severe ischemic pain. So then she occluded again, had severe ischemic pain. I reopened her, had another. And at that point I said, okay, we're going to do it. Severe ischemia on like the first week, the whole thing necrosed, and we had to do a BKA. And that's the patient that I just don't know if I should have just primarily done a BKA rather than put her through all of this. It's hard, right?
It's hard.
But I will tell you something, that I was so transparent to the family. I literally put the numbers on a paper that within the first 2 weeks when things weren't going, she was like, it's not going to work, right? We're going to have to do this amputation. And I said, yeah, I think we do. And she's doing well. I mean, she healed the VK and she's fine. And I heard the other day that she's apparently going to be fitted for a prosthetic, which I thought she'd never be able to walk. Who knows? But it's still a big question mark as to, there is a finite group of people that actually accelerate.
Yeah.
And I think that I just don't know how to identify them yet. And to your point, maybe we'll learn a little bit more of how to do it.
How do you think about flow volumes, Roberto?
I think that you have, for example, the paper by Michael Shrieve, Stephen Kamm, etc., that when you go down 200 or 195 milliliters, I think, per minute, you have a high probability of occlusion, for example. The problem is flow volume is something very difficult to understand. In some cases, I put a pressure wire inside the venous arch after foot vein arterialization. And what you see is very difficult to be interpreted, because you see maybe that the patient is 120 to 80 milliliters of pressure, maximum and minimum. In the stent, you see a mean pressure of 60 or 50. In the venous plantar arch, you see a mean pressure of 20 millimeters of mercury. 20, only 20. Why? Because you have all this tail effect. If you close with your finger the superficial grits affina vein at the ankle, you see that the mean pressure from 20 goes up to 30 immediately. So the blood flow is the result of the balance between the inflow, the effect, and the vein outflow. So if you embolize, you surely will have a reduction in blood flow and an increase in the pressure. But at the beginning, if you increase too much of the venous pressure in the foot, when the foot vein arterialization has not matured, you will reduce completely the gradient between all diseased arteries, capillary, and veins, that is still the only feeding for foot tissues. So, all from a pure hemodynamic point of view, all these measurement, pressure and blood flow are correlated. And it's very difficult to understand how to move. This is the problem. We have not rules now. We have only personal experience, good sense, but this is the reason why today we are able to guarantee a 70% of success. And in many cases, we don't know how it's possible. But we need more data, I think, more studies.
How long ago was it that you did your first EVA? And how did you come to the understanding that this was a necessity?
I think it was about 15 years ago.
Wow.
Then I met Tim Lehinihan, the founder of Flaw. He wanted an expert in CLI at those times, was the name. And we started the project of Flaw. With, for example, the push valvulotome was an idea of mine because I selected all the valvulotomes. I'm not a vascular surgeon, but I selected all the valvulotomes on the market, and I decided that the Andromed probably was the more delicate. So we mounted this valvulotome on a stiff shaft, and we made some cadaver lab in Singapore with Stephen Kam, and we inside the Grisafina vein, we registered with video the action of this valvulotome push, and it was very, very delicate. So we decided to use this, the cover stent, the conical shaped stent from artery to veins, etc. All this stuff. So it started about 13 years ago with Tim. Then after animal lab, cadaver lab, etc., Stephen made the first in man in Singapore, an 8 patient. And I think that 10 years ago, I became a believer of foot vein arterialization because at the beginning I was very skeptic, frankly.
Oh, really?
and we're I think all of us. Were you at the time? Was it clear as it is now that there was a very clear niche of patients that would benefit from it at the time, like in 13 years ago? So 13 years ago, you had already identified the small arterial disease.
I was starting to identify.
Okay, so you in a way you're like, this can be a solution for this problem that I see happening more and more.
This epidemic of SAD MAC.
Because you hadn't published at that time the SAD paper, right?
No, because it was refused by 5.
The resilience of the MacGyvers.
Yeah, of John Wayne.
We just had a great conversation before.
Everyone answered to me, this is not important. What you say is not true.
Yeah. Thank you. But at this point, reviewer 1 and reviewer 2 think your work is trash.
Crazy. Exactly.
That's exactly how I read it.
Talk to us about phosphate. We were talking about phosphate before.
We talked about
phosphate,
the soda, and what your hypothesis. Because I'll frame it. We were having a conversation earlier as to what are the potential explanations to this advent, this massive increase of medial artery calcification pattern. And, in my mind, it has something to do with diabetes. I find that it happens more in renal failure patients. So there's certainly some degree of derangement related to electrolytes in some way. I've seen hypotheses printed where high phosphorus and high calcium states change the smooth muscle cell phenotypically from a normal acting to an osteochondrocytic smooth muscle cell. And it starts creating deposits in the media of calcium, essentially bone creation, right? You see rims of bone. But Roberto pointed out something interesting that he has as a hypothesis to why this could be. And I think this is what he was alluding to.
Now, what we know today is that medial artery calcification is related essentially to 3 risk factors. The first one is aging, obviously. The second one is diabetes. The third one is hemodialysis, chronic kidney disease and hemodialysis. So this is clear, absolutely clear. The second thing that we know is that medial artery calcification is a very slow phenomenon. There is a paper on 1985 by Evera regarding more than 4,600 Pima Native Americans that are a tribe particularly prone to develop diabetes. So they studied it. And they wanted to study medial artery calcification, correlation with diabetes. So they made every 2 years plain X-ray of the hand, the thigh, the leg, and the foot. So something that today cannot be so acceptable. 4,600. And also the pelvis. They avoided to do the pelvis X-ray only to
Fertile
women
and fertile ages.
before the 45. Yeah. And they found that there was an increase of medial artery calcification in every district, starting from the age of 30 and rising more than 70% or 80% after 70. So you need decades to develop this medial artery calcification, which is a diffuse disease in every artery of the body. So this is the second. The third thing is that we know very well that medial artery calcification is what we called in a JACC review the silent killer of the cardiovascular system, because you lose every Wing-Kessel effect of all the elastic arteries. So you have an increased pulse pressure, an increased pulse weight velocity, and all this stuff is correlated to precocious cardiovascular death. By the way, the problem is that only in patients on hemodialysis, where we are able to control everything, we know that medial artery calcification is a killer, and we can treat this medial artery calcification. How? Acting on the balance between phosphorus and calcium metabolism in 3 ways. A good quality of dialysis. This is a key point for survival of the patient. The second key point is the use of drugs such as sevelamer, lanthanum, which is taking phosphorus from absorption in the bowel. And the third key point is the diet. There are a lot of papers demonstrating that patients on hemodialysis that follow a good diet regarding protein intake have a survival which is much more longer than patients that don't follow the diet. And other papers...
That would be a low protein diet, low animal protein diet.
And there are also papers demonstrating that patients on hemodialysis that have a high-level income survive much more of patients with a low-level income, essentially because patients with low-level income cannot buy vegetables and cannot have time for cooking all this stuff and eat a lot of trash food. And so we know that in patients on hemodialysis, the intake of phosphorus is a key point in developing medial artery calcification. As I said you before, the phosphorus in the vegetables is imphytate and it's absorbable only 30-40% and very slowly. Phosphorus in meat is absorbed faster and is absorbed about 40-60%. But what is today a post-Second World War epidemic is the intake of inorganic phosphorus, which is present as a conservant in a lot of trash food, in a lot of
soft
drinks,
Drink
especially cola, drinking, cheese, etc. So we know that this is true for patients on hemodialysis. Looking at this epidemic of medial artery calcification in patients, all patients that are not in hemodialysis, I suggest, I think it can be very interesting to see if what is called the carnismo in Italy is called, the meat eating that is typical of the last 50 years, that increased a lot because meat was not the principal type of food in the last century. Today, there are people that eat meat 2 times per day.
Well, there in the U.S., there's a big fad of that's called a carnivore diet, which is you only eat meat.
Yeah,
You don't eat
I know.
anything. So that would be a very easy study because
And also the soft drinks
Yeah.
and all these conservants,
I
phosphorus based
I
in fresh food.
yeah I think I don't think I don't have no evidence for this for what I'm saying, but I don't think meat is the problem. I think the problem is these processed foods and high carbohydrate diets, and the reason I have this hunch is that I've had very few. So every single time I had a diabetic patient, I have a spiel I give him. I tell him, I'm gonna do my homework. I'm gonna operate on you, and I'm gonna give you 100% of me, and you'll have 100% of me. Okay, but you have to do the same, and the way that you do it is three very simple things. Rule number one: if it's sweet and it's liquid, don't put it in your mouth. Rule number two: if it comes in a box or a package and it has marketing that's telling you to eat it, don't eat it. And then rule number three: go to Amazon, get some stretch bands for $20, and exercise at least one muscle group until it burns. Those are your three homeworks. And the patients, very few patients do it, but the patients that do go from a hemoglobin A1C of 12, 10 to 5 in like a month off medications. I've had like three that said like I follow your rules to the and they don't recur. I never see them again. I see them like they call me once like, hey, I'm doing great, thank you so much.
Because they hate you, they don't want to see you anymore.
Maybe. Yeah. Yeah. So
Yeah, no wonder it's only 3 people.
This is
yeah,
mad.
yeah.
This is mad.
It sounds like you need to work more, is what I think. If only 3 people have adhered to this, how many patients do you have? You should have hundreds of patients. What are you talking about?
That I
3?
convince them to change their what they've done for 30 years.
You've
That's
only
not easy.
got 3?
That I can think of right now out of my mind. Yeah.
You need to do a better job. You suck at this.
I do suck at it. Yeah, I'm trying at least. Yeah.
You
Most
probably
people,
did,
most surgeons don't
you
even
probably
try.
did 500 surgeries
Yeah,
last
but
year.
how many surgeons tell their patients to like change their lives because there's only so much I can do.
Yeah, no. I think that we have a lot more to do in that sense. What do you think? Where do you think the next 10 years of research in the deep venous arterialization may bring? Do you have? And I know you have like a lot of ideas, and some of them are probably still copyright protected. So don't share your $1 billion idea.
Yeah.
I want to go to your yacht.
Yes.
One day.
Can
in
we
the
record
future.
the podcast
But
from your yacht?
I will say
I can
this.
assure you that you never come in my yacht one day because the yacht will never.
It's going to be a toy yacht in your hand. But
or
in
the
general
villa.
terms,
We can do villa.
Villa's
I'll
fine.
take a villa.
And just in general terms, thoughts on where you think this may go to?
They're difficult to say. I believe that, first of all, the technical procedure is something that can be repeated in much more centers. Absolutely. In a lot of centers. From a pure technical point of view, we can improve it a lot. We can improve it. The second thing that for me is a key point, that today, as you said before, it's difficult for you to decide what to do with the patient. It's difficult for me, it's difficult for you. But the main problem is that we need to take this decision not alone. This is no more possible. We are still in an era where single physicians take decisions that, despite the ethical pathos behind the decision, must not be taken by a single man. We need the creation of multidisciplinary team. I have appreciated a lot in the global vascular guidelines that they put this as a key point to have palliative care experts. Today, we think that palliative care should be used only at the end of life. This is not true. Now we are talking about contemporary palliative care, simultaneous palliative care, because palliative care physicians are able to construct a relation with the patients and the family and to be able to face future problems that are imminent problems for the patient with CLTI, because we know very well what is the death rate of these patients, with the construction of a relationship to help these patients in the short time that this patient has to live. And so we need to have a palliative care consultant next to us. This is a key point. How much money are we spending doing procedures that have no any sense? To prolong life maybe for a few weeks or months without any sense. We need to think about quality of life, and we need to treat chronic intermittent ischemia in the context of a multidisciplinary team where we that are lover of technology, of interventions, can participate to the decision offering our techniques, but the decision must not be one of us decision. This is the problem. This is the problem of industrial medicine. In all this congress, we see wonderful things regarding lesions, patches, but the patient is more than his disease or her disease. It's not a lesion, a patient. A patient is a life, a family. So we need to come back and to be able to talk with patients. We have no time in our center. I have no time. You have no time. We are operators. So we need physicians able to have time and to talk with patients, with all the family, in order to create a pathway toward the end of life properly, where intervention can be done, but must be done properly when intervention have exactly a good meaning for the life of the patient, a good success for the life of the patient.
It's
I agree.
we have a term for it at Hope, and we call it wound hospice. And so
Great.
what we do is when there is, let's say 92-year-old with a necrotic fifth toe, yeah, for example, last week, protoplasm is not great. You see there's cognitive, they're maybe moving around very, very slow, or maybe in a wheelchair. Family is hysterical. They need some solution for this necrotic toe. And it takes a lot of time, but at the end of the day, I asked the patient, "Are you in pain?" And he said, "No." And there's no infection. Okay. So after ultrasounds and all these things we did, I sat down with them for a while. And what I said is, listen, you're going to put betadine on this necrotic little toe twice a day, and you're going to forget about it. And as long as this is not infected and as long as he's not in any pain, there's no reason on earth for me to put this gentleman through a DVA at 92. Well, I don't even know I don't know what's going to happen next. And I sure as hell, I don't even know if this is going to help him, or I'm just going to accelerate his death and send him in a box real quick. So we are going to do wound hospice care, and you're going to forget about that. And you're going to be, and I assure you, you're not going to die from a necrotic toe. You have a higher odds of dying when you drive home to come and see me again if you need to come, than dying from dying from that toe. Yeah. But what a good way to wrap the conversation, Roberto, because it is really true that part of what we do, we talked about it at the beginning, is we're just palliative care physicians, period. Right? We're not curing a vessel, we're treating it as and hopefully keeping it going. But there has to be a very clear understanding of what the goal is at a human level, at a patient level, at a quality of life level. And despite all the gadgets and gizmos and things, there comes a point where doing something is probably not the right thing. So consulting seems like also a very good thing. there should be more discussion and more consulting before you put somebody through some of these very complex care pathways. Listen, I want to be sensitive to the time. I know you've got like a million presentations like you usually do. And I want to say thank you from the bottom of my heart for sharing some of your thoughts. This is a super intimate conversation, which we love having here at the Life of Flow. Hopefully the first of many more. And also you gave me the best news ever. I think a year ago you said you were going to retire. And like every good operator out there, you were full of shit.
Yeah. They pulled me right back in.
You went back. You stayed for 1 week at your home and said, I have to go back. And so I'm glad that you're back at it and you're working three days a week or what have not, or whatever that is, man. It makes me really happy. The world needs you. We need you. And thanks for sharing your time with us. Okay.
Thank you so much.